So the green button is forward, this is backwards, and this is the pointer.
Well, thank you very much. It's always a pleasure to be back now with a change in venue from Washington to Chicago. So I know that about 40% of you are not here for a board review. You're here for a refresher, for an update. But the focus of all my talks still is on board review. There will be some items that are related to update that will certainly not be on the boards, but still the focus is typically on board reviews. And for this acute kidney injury talk, my goals are to first review the definition and the clinical relevance of acute kidney injury. Then we'll talk about a couple of selected topics in terms of prevention, some issues about the overall diagnostic approach, and then talk about treatment with a focus on, again, selected issues primarily related to dialysis. So to get going, the definition of acute kidney injury is one that has been quite varied over the years. So for the sake of uniformity, especially for publication and data analysis sake, there's since 2004, there has been a set of criteria for the diagnosis of AKI. And the first one was the rifle criteria, which you can see has items related to both changes in serum creatinine as well as changes in urine output. And rifle had two items that were related to outcomes, which was the loss of renal function requiring dialysis for more than 4 weeks, and then finally the end-stage renal disease outcome component, which was when patients were on dialysis for more than 3 months. Those two outcomes items were removed in a new consensus definition published 2 years ago called the AKIN, the Acute Kidney Injury Network set of criteria. And they are still essentially the same in terms of the thresholds for changes in serum creatinine. They are the same for changes in urine output. The only thing that changed were a couple of items. One, there was the addition of the change in serum creatinine by only 0.3 milligrams per DL. And the reason for that is because there are data that I'll show you in a second indicating worse outcomes in patients who have even these minor degrees of changes in serum creatinine. The second change is that now we have a window of 48 hours to make the diagnosis of acute kidney injury. So this is just to make the definitions a little more tight. Now, what is the clinical relevance of acute kidney injury, which occurs in up to 30-35% of patients in the ICU, at least about 5% of all hospitalized patients. So certainly a very common event. I don't need to remind you of that. But importantly, there is definitely an association between acute kidney injury and outcomes, in particular mortality. So these are two meta-analyses published by my colleague Steve Koka. The first one looking at in-hospital mortality. We published that several years ago, looking at mortality at less than 30 days. And what you can see is there is a dose relationship. Minor changes in serum creatinine are associated with about a 2-fold relative risk of early death. As you go up to changes from in the 0.5 to 0.9 range, that increases to almost 5-fold. And when you get to changes in serum creatinine that are greater than 1 milligram per DL, the mortality, the risk ratio for mortality there is almost 10-fold compared to patients who did not have that. Now, new data are related to long-term mortality. So these are typically 6 to 12-month mortality rates, in some studies longer than that. And the data presented here as in changes in creatinine. When greater than 25%, you see about a 2-fold increase in risk, and then goes up to 2.7 and 3.1 as you move on all the way to requiring dialysis. So the message from this is that acute kidney injury is associated with worse outcomes, and there is a dose relationship in terms of severity of the changes in renal function and the observation of increased mortality. In addition to that, there's obviously an increase, I shouldn't say obviously, but there is definitely an increase in the risk of dialysis dependence. Up to a quarter of survivors required to be on dialysis and permanently. And in addition to that, there's an increase in length of stay and increase in costs. The data on costs are primarily Medicare based, but we know from experience that also in younger patients, there's also an increased cost and length of stay associated with acute kidney injury. So there's an impetus to get these patients, to prevent the occurrence of acute kidney injury as best we can. And unfortunately, this is not always possible because patients come to us very often already in acute kidney injury. But since there's a significant number of patients who develop acute kidney injury in the hospital, it's important for us to at least remember some of the basic tenets of what we have to do. And those include adequate volume and hemodynamic management, trying to maintain renal perfusion. The question of tight glucose control, this is now obviously an issue. We don't know what we're doing in terms of outcomes of patients with tighter control, especially in medical, non-surgical patients. But at least the early data, especially the Vandenberg studies, showed a decrease in acute kidney injury in patients who had tighter glucose control. In a meta-analysis of the available data, this did not hold out. So there was no difference in either changes in serum creatinine, although there was a trend, and there was no difference in the need for dialysis. So it's uncertain if that has much of a value based on a broader analysis of the data. We obviously have to try to limit exposure to nephrotoxins, change doses whenever applicable, and finally, use preventive strategies whenever possible. And I put here 5 of them. In patients who have cirrhosis, make sure to use albumin when patients are receiving large volume paracentesis, or in patients who come in with spontaneous bacterial peritonitis. For those few patients that still receive AmphoB, remember to prehydrate, and certainly if there is underlying renal insufficiency, definitely use the liposomal preparations. Patients receiving aminoglycosides, we've got to make sure to dose adjust, and the use of single daily dosing is associated with less incidence of acute kidney injury. But I'd like to spend a couple of slides talking about 2 common problems that can be prevented, which are contrast nephropathy and tumor lysis syndrome. So, contrast nephropathy. The first item of importance is defining who is at risk for developing contrast nephropathy. And this is primarily indicated in patients with underlying kidney disease. These are really the people to go after. So if you have impaired GFR below 50 to 60 ml per minute range, those are the patients to really target. There's added risk if the loss of GFR is related to diabetes. There's increased risk if patients are hypotensive, if they have low left ventricular ejection fraction. There's a statistical relationship with anemia. Older patients are at increased risk of just about any type of kidney injury. And with the specific issue of contrast administered during cardiac catheterization, there's definitely an increased risk in patients who are receiving an urgent rather than an elective procedure. Now, we've known for almost 30 years that hydration, so sodium-containing hydration, is effective in decreasing the occurrence of contrast nephropathy, especially in patients with these risk factors. Now, our current preference is to use a bicarbonate-containing solution, although I'm going to tell you this is definitely not based on strong data. There have been a large number of meta-analyses, and since I submitted these slides a couple months ago, there has been another very good meta-analysis with essentially the same results. But as you can see here, when patients receive isotonic bicarbonate, so a solution that typically, 1 liter of D5W with 150 milliequivalents of, 3 amps of sodium bicarbonate, compared to isotonic saline, so normal saline at similar rates, the incidence of laboratory AKI, varying among the studies, but typically somewhere in the range of an increase in serum creatinine greater than 0.5, is there's a trend towards less laboratory AKI in patients who receive bicarbonate, but as you can see, the confidence intervals vary, and here and there's large heterogeneity in the studies. But here, despite the wide confidence interval, it does not include the unity, so the general agreement is that we do see less laboratory AKI. There's possibly less dialysis requiring AKI. This one, even though the relative risk is decreased, you see a wide confidence interval. And I want to point out to you that the rates of dialysis requiring AKI are quite low. Now, having said that, because the only difference here is that it's a little more labor-intensive to administer bicarbonate. You have to prepare. There's no commercially available solution of isotonic bicarbonate. There is an argument about this. Now, there is probably going to happen, the VA is going to probably sponsor a very large clinical trial to definitively settle that question. It's going to cost about $15 million. I think it's a waste of time and money, but others don't. So we will have that answer sometime in the near future. But right now, our practice based on these data is to use isotonic bicarbonate. We should also use non-ionic, low osmolality contrast in the lowest amount possible. Now, low osmolality is not really isoosmolar. Low osmolality are contrasts that have osmolalities between 600 and 900 milliosms per kilo. And those are the ones that are associated with definitely less risk than the high osmolality ones. They have an osmolality of about 1,500. Now, isoosmolar contrast, the predominant one being iodexanol, it is unclear if it is of benefit. In a meta-analysis published last year of the two, there is the point estimates are not suggestive of a benefit. So this ends up being used for patients who are at high risk of contrast nephropathy, especially those with very low renal function, say GFRs below 30 mLs per minute. But this is arbitrary. There's uncertain value of everything else that I list there, or no value for the ones at the bottom. The one that I do want to point out is Mucomist. And there have been a large number of meta-analyses looking at it, probably more meta-analyses than original studies. And the bottom line is that it certainly does no harm. It may do some good. So our practice, given the low cost, is to use it in patients. A recent review actually used this recommendation. Use of N-acetylcysteine is not unwarranted given low risk and low cost. Not unwarranted. This is a kind of a funny way to say go ahead and use it. We certainly still use it in our practice and typically with double dose. So we typically use 1,200 milligrams 4 times a day, twice a day times 4 doses starting the day before of the procedure. Very good. Prevention of tumor lysis. So for those of you who practice in areas, in hospitals with large cancer centers, it's a very frequent problem, especially in patients who come in with high-grade lymphomas or in patients with acute leukemias. So it's important to recognize. You see there the diagnostic criteria for laboratory tumor lysis syndrome, which is an elevation in uric acid, phosphate, potassium, or a decrease in calcium. And clinical tumor lysis syndrome, which is when those manifestations become clinically apparent. So the patient develops acute kidney injury, typically either due to increase in uric acid or in phosphate. They seize because of hypocalcemia, or they have arrhythmias related to hyperkalemia. Now, the risk factors are of 2 types. One, the tumor type, so especially high-grade lymphomas and acute leukemias. and also the tumor burden. So especially in acute in lymphomas, looking at the overall mass of the tumor, and in acute leukemias, especially when it's a lymphocyte, when in ALL white counts greater than 100,000, in AML white counts somewhere greater than 10 to 50,000. But there are also some patient factors, and the most important patient factor here is the presence of underlying chronic kidney disease. So underlying kidney disease predisposes to all sorts of acute renal failure, and that's certainly the case in patients with tumor lysis. Now, what happens there is as tumor kill happens, potassium, phosphorus, and purine are released. Potassium release causes the clinical complication. Phosphate release can cause the clinical complication related to hypocalcemia. And the purine release, by metabolism going down the pathway of hypoxanthine, which is minimally toxic, if toxic at all, xanthine, which is potentially toxic, and then uric acid, which is definitely toxic. These are the pathways to develop kidney injury. So the most common form of kidney injury is acute uric acid nephropathy, so it's important to control uric acid. Patients who receive allopurinol which blocks xanthine oxidase, and xanthine oxidase is going to catalyze this conversion to hypoxanthine and from xanthine to uric acid. So you end up having an accumulation of both xanthine and hypoxanthine. The accumulation of xanthine has been well documented to cause acute xanthine nephropathy. So it's something to keep in mind in patients who receive allopurinol, and this is actually one of the reasons for the recommendations, and these are consensus recommendations on the prevention of AKI, which state that in patients who are at low risk, you probably don't need to do anything. You just use clinical management and monitor. These are patients with, say, solid tumors or very low-risk tumors, such as a low-grade lymphoma or a patient with an AML without any significant features. For example, an AML without large burden. Now, in patients with intermediate risk, those patients would receive hydration, and this is how to hydrate. You really want to keep a high urine output in the 200 to 250 mLs an hour, and if the patient's definitely well hydrated, you may need to use furosemide to prevent volume overload along with that, so forced hydration. Allopurinol works quite well in these patients. And it's certainly cheaper than resburicase. So their recommendations was to use resburicase in children because there are more data in children, and to use allopurinol in adults. Now, as you move to high-risk patients, then the recommendation from this group is to use resburicase. Resburicase, for those of you who don't know, is a recombinant uricase form. It blocks, it catalyzes the conversion of uric acid to allantoin, which we don't do. High primates and humans don't do that. It allows you to do that, and allantoin is very easily excreted in the urine. It's highly soluble, so it's a non-toxic metabolite. So what this management does is it takes away the role of uric acid in acute, in tumor lysis. So it makes management easier. Does it make any difference in terms of outcomes when compared to allopurinol? The answer to that is no. There have been 2 clinical trials, one in children, one in adults. The one in adult not yet published, but presented in abstract form in the hematology meetings. And it makes no difference. So the only difference that it makes is that with resburicase, you have immediate reduction of uric acid. For those of you who have used it, you know that a couple hours later you don't see any uric acid around. Whereas with allopurinol, the median time to achieve control of uric acid is about 24 to 27 hours. But that's the only difference. So having said that, I think that what really makes a difference is that by using resburicase, and typically a single dose will take care of the problem, you get the uric acid out of the equation. Now, moving to the patient with established AKI, it's always important to remember this basic framework that all of you learned since medical school, pre-renal, intra-renal, and post-renal approach. The reason I put this slide up is that you need to remember to go through that so that you don't forget to consider the possibility of obstruction just because the patient doesn't tell you that there are no symptoms. You need to formally go through those. Make sure that you analyze volume status and possible causes, and make sure that you use an appropriate diagnostic approach to think of intrarenal causes. So what is this diagnostic approach? I'm going to discuss that right after we go through this question. So 60-year-old man under your care in the ICU following open repair of an infrarenal AAA. His postoperative course was complicated by an MI and aspiration pneumonia. Between postoperative day 10 and 13, while he was euvolemic and hemodynamically stable, his creatinine goes up from 1.2 to 2.6. His urinalysis shows 1+ protein, 20 to 25 white cells per high power field, 3 to 5 red cells. His FeNA is 2%, his urine culture is negative, and a renal ultrasound is unremarkable. Of the drugs he's receiving that are listed below, which one is most likely associated with this patient's acute kidney injury? Piperacillin tazobactam, valsartan, bacitracin, clopidogrel, or amlodipine? Okay, so the answer there is A. That's the correct answer, and not the modal question, but several of you got it. So let's go over that answer. So why is it A? Because this patient has a couple features. He had an aspiration pneumonia. He was put on antibiotics, and several days later, not said here exactly how many days later, but several days later, while on antibiotics, he develops acute renal failure that has a lot of pyuria. So there's pyuria, the fractional excretion of sodium is elevated, so this patient likely has an interstitial nephritis. And of the drugs listed, the only one that's classically associated with interstitial nephritis are beta-lactam antibiotics, in this case, Zosyn. Now, it would not be, so valsartan, there have been very, very rare reports of ARBs causing interstitial nephritis, but that's not what that would not be a typical presentation. It usually causes hemodynamically mediated ATN, in which the kind of urinary sediment would be different, as I'll discuss with you in a second. Bacitracin topically has not been associated with any syndromes that I know. Clopidogrel is associated with the hemolytic uremic syndrome, would present differently from this, and amlodipine is not associated with any syndromes other than hypotension related. And I say in the history that he's euvolemic and hemodynamically stable. So what are the tools that we use for the differential diagnosis of acute kidney injury? We obviously have to look at some historical and physical examination issues. Certainly in the history, the presence of recent invasive procedures, primarily looking for atherembolic renal disease, and for the use of nephrotoxins. This is typically what happens when patients are in the hospital. And in the examination, by far, the most important issues are related to the patient's volume status, either on the low side or on the high side, both being associated with impaired renal perfusion. But there's really a triumvirate of tests that we use, and that triumvirate is composed of renal imaging, making sure that the patient's not obstructed, and that's typically an ultrasound, urinalysis, looking at the urinary sediment, and the use of urinary indices, especially the fractional excretion of sodium and the fractional excretion of urea. I put here bladder pressure because that's important. Now there's certainly an increased interest in the role of intra-abdominal hypertension in mediating acute kidney injury. So it's important to have that in mind, especially in post-op and trauma patients who have received massive resuscitation. So those patients, it's always important to keep that in mind and look for intra-abdominal hypertension, primarily based on bladder pressures. At least that's the way we do in our practice, even though there are other means of measuring it. How about the urinalysis? How does it help you? Well, in prerenal azotemia, you don't see anything. Sometimes you see some hyaline casts, so very bland urine. In tubular necrosis, you typically see some tubular epithelial cells and granular casts. Those are the muddy brown casts. And as I'll show you in a second, the more of these you see, the more likely it is that the patient has ATN. In patients who have glomerulonephritides or vasculitides, you want to see red blood cells and or red blood cell casts. Now, sometimes all you see is hematuria, but red blood cells, especially if dysmorphic, and red blood cell casts are very important in the diagnosis of these processes. And finally, in interstitial nephritis, you want to see white blood cells and white blood cell casts. You sometimes see, as you did in this case, sometimes you see a few red blood cells, but the predominance is really of white cells and white cell casts. Now, the urinalysis now is known to give you some valuable information in distinguishing from prerenal azotemia and ATN. These are data from my colleague Mark Parazella. And what you can see is that in patients who do not have any granular casts, and that's also true for tubular epithelial cells, but much better for granular casts, the likelihood of ATN is significantly lower than prerenal azotemia. Then, as you start seeing more and more granular casts, and here when you get to the 6 to 10 granular casts per high power field, which we see relatively often in these patients, then the likelihood ratio for being ATN is 10. So much, much more likely that this patient will have ATN rather than prerenal azotemia. And so it is an important finding, and I think we need to make sure that if for those of you who don't look at the urine sediment, to make sure that your laboratory is equipped to do that, and for the rather than just relying on the auto read, that the technicians actually look for these in the sediment. How about urinary indices? The major value here is for patients, especially patients who are oliguric with acute renal failure. It's in distinguishing prerenal azotemia from ATN. And if the urine sodium is low and the fractional excretion of sodium is low and the fractional excretion of urea is low, those all point in favor of prerenal azotemia. If they are high, they point in favor of ATN. The value of the fractional excretion of urea is especially in patients who recently had a dose of diuretic. 24 hours later probably doesn't make any difference. But if you want to make a diagnosis early on, the fractional excretion of urea is not affected by recent diuretic dosing. Now, I want to show you this slide, not to go over this list. In blue, you see the most common ones, but really what I want to tell you is how broad the relationship is between drugs and acute kidney injury. It can happen by a variety of mechanisms: systemic capillary leak, changes in intrarenal blood flow, glomerular injury, those are not particularly common, tubular interstitial injury, either as tubular necrosis or as interstitial nephritis, and those two are the most common causes associated with drugs. And it can happen as crystal deposition or very rarely retroperitoneal fibrosis, because we don't use those drugs anymore. But the bottom line is, think drugs. Every time I see a patient with acute renal failure as a consultant, the thing I spend the most time with is figuring out what has happened volume-wise, blood pressure-wise, and what is the drug list, what it is that we have done to the patient that could have affected his progression to acute renal failure. Now, this is definitely not going to be on the boards. It's an evolving area of biomarkers. I quote here the most recent review. This is done by my colleague Chirag Parikh. This is a biomarkers for acute renal failure are substances measured either in the urine or in serum, trying to detect acute renal failure earlier or trying to detect the risk of acute renal failure. These are substances, some of them are just markers of tubular injury, others are markers of GFR, like cystatin C. Others are actually protective substances, such as NGAL. that then get, there's more shedding because they are produced by renal cells. So there's a wide variety of names, and that's of lesser relevance. But the relevance here is that we are trying to catch the process early on so that maybe we can reverse the likely, historically we've been unable to treat acute renal failure by any means. The idea here is that if we can identify patients at risk or identify even the presence of acute renal failure, if it's a day or two before the rise in serum creatinine, that we might be able to employ earlier interventions. And these are some of the names, and they are associated with either the early diagnosis of acute kidney injury, the early prediction of development of AKI, and most of these have been tested in situations where you know when the hit happened. For example, cardiac surgery, exposure to contrast, so you know when the hit happens, and you see how the behavior goes in the future. And finally, to predict the severity of AKI. So these things will be coming as in the next few years, and we are involved in studies looking at this for both diagnosis and prognostication in acute kidney injury. One such study, you have the graphs in your handout. This is a summary of the Nicholas study. 635 patients admitted to the ED at Columbia in New York. They measure NGAL, neutrophil gelatinase associated lipocalin. This is a substance that has protective effects. It has antimicrobial activities. It has antioxidant activities in the kidney, predominantly secreted by the loop of Hanley and the distal convoluted tubule. And what they showed was that in patients who had ATN compared with just pre-renal azotemia, chronic kidney disease, or normal renal function, so patients with ATN had a 14 to 26-fold increase in the levels of this substance in the urine. And that elevated NGAL was the strongest predictor of the combined endpoint of nephrology consultation, ICU admission, dialysis, or death. Unfortunately, they do not present data for each of the individual endpoints. But there appears to be an increased prediction based on graphs without the odds ratios for these patients. So it seems that this not only allows you to detect, there are other data showing that it allows you to detect earlier, but it allows you to detect acute kidney injury and allows you to make some statement of prognostication, at least related to renal outcomes. How about the management of acute kidney injury? So, unfortunately, there are very few specific strategies. There are some patients who come in with an acute glomerulonephritis. We can treat the acute glomerulonephritis. Acute lupus nephritis, we treat the lupus nephritis. Patients who come in with pre-renal azotemia, we replace volume. We correct the heart failure. We treat the abdominal compartment syndrome. So those things are possible. But most of the cases, we end up with general supportive measures. And those are stated there just so that you are reminded of the importance of avoiding further injury, making adjustment in doses. This is by far the thing I think we contribute during consultation. Very often, you or your pharmacist rounding with you fail to adjust medications. Remember, creatinine went up from 1 to 2. The GFR is not the calculated GFR that's being reported associated with a creatinine of 2, which is typically, somewhere in the 30s. The GFR is 0. Creatinine went from 1 to 2 from yesterday to today. The GFR is 0. And you have to adjust the medications accordingly. So you need to remember that. In addition to that, there'll be issues related to management of nutrition, electrolyte, acid-base issues. But is there anything else that we can do? And in the non-specific management strategies, I've talked about a bunch of things over the years, but the only one I really want to say something about right now is diuretics. And diuretics do not improve the course of renal failure. They do not alter mortality. But they do make people pee more. And if they make people pee more, it sometimes, very often, makes the management of volume overloaded patients easier. So it's not like you can't use diuretics. You should use, but only to manage volume overload. There are some discordant findings in the literature in terms of impact on mortality. Picard's study was a North American study. BEST was a multinational study. So one says it makes a difference. The other one says it does not make a difference. But in Picard, the reason why it probably made a difference was because people just sat on the diuretics for too long rather than calling in the nephrologist and starting dialysis when dialysis was required. So that's probably the confounding factor. So the message from me is that you should use it if the patients are volume overloaded, but you should not use it for too long. If the guy didn't respond to escalating doses of, say, furosemide, moving all the way to a drip, you didn't get him to pee in the first 6, 8, 12 hours, he's not going to pee 2 days from now. It's not going to happen. So call in the dialyzers. If there's volume overload, that's the way to manage the patient with ultrafiltration. So just make sure that you don't delay the use of other interventions, especially dialysis. So I'd like to talk to you for the last, 5 minutes or so that I have about dialysis issues in the ICU. So these are the classic indications for dialysis. You all know this. Clinical uremia, diuretic-resistant volume overload, refractory hyperkalemia or acidosis. Now, those are sort of non-controversial. Nobody talks about it. But there are some controversies about in the patient who does not have uremia or any of those volume or metabolic complications, whether you should start them early or late. I'll show you some data on that. The other two key questions I want to discuss with you is choice of modality and finally the intensity of dialysis. So in terms of early initiation, there have been many studies over the last almost 40 years now, and this is a meta-analysis published 2 years ago looking at mostly cohort studies and a few randomized or quasi-experimental studies. They looked, these data are looking at biochemical values, especially BUN, at the time of initiation. And there's a wide range. For example, the range of early initiation was between the mid-40s and the mid-160s for BUN. Okay, so wide heterogeneity among studies. The range for late initiation was between the mid-70s and the low 200s. So just keep that in mind. These are very heterogeneous data. And what it shows is that looking at mortality up to 6 months in different studies, patients who had early initiation of renal replacement therapy had about, in the randomized clinical trials, you see here a death rate of about 25%, 41% in the late starters. For cohort studies, mortality of about 45%, 61% in the late starters in these cohort studies. So that came up with risk ratios of about 0.64 and 0.72 for randomized clinical trials and for cohort studies. So in the randomized clinical trials, and these were very small, typically old clinical trials, there was a trend in reduced risk, but since the confidence interval crosses the unity, it did not reach statistical significance. In the cohort studies, that decrease did reach statistical significance. So the bottom line is that given this mindful of this heterogeneity, we probably should not start people too late. What is not starting people too late? We don't know. So our practice is to not let anybody go with BUNs over the 100 range, with the possible exception of people who are overfed, very hypercatabolic, with very low creatinines, and you measure the urea and creatinine excretions, so clearances, and you see a pretty good creatinine clearance and a very low urea clearance. So these are people who are often volume depleted. But this is, these are the low quality data I'm basing this recommendation on. Very good. How about modality of dialysis? We have several ways that we can treat acute renal failure. Most used in this country, and acute PD is really not used anywhere else anymore. So it's mostly intermittent hemodialysis and continuous or semi-continuous modalities. For continuous modalities, it's CVVH, continuous vena-venous hemofiltration. Not too many places in this country use that. Most places here use continuous vena-venous hemodiafiltration, in which you do both hemofiltration and hemodialysis with the apparatus. SLED is slow, low-efficiency dialysis, which is typically done 8 to 12 hours a day in most places. This is what we use at the VA. At Yale, they use primarily CVVH-DF as the modality. As you can see here, there are some differences. So when you compare intermittent hemo with continuous modalities, intermittent hemo is very easy to do. Now, continuous modalities are easy to do if you are set up for that. If you're not set up for that, it's a major nightmare. Every nurse complains about it. If you have a greased environment, the nurses complain when you have intermittent dialysis because the dialysis nurses come there and get in their way. So it's mostly an issue of what works for your environment. The control of solutes tends to be better if you have a continuous modality. And hemodynamic stability, I will show you, is probably a little bit better in patients on continuous modalities. Now, what are the effects on mortality? Summary here, 3 meta-analyses. As you can see, probably no difference. The way the data were analyzed, the types of studies included differed a little bit. So some improvement here in one meta-analysis, no improvement in the other 2. This is looking for a favorable effect of continuous modality. So I think that the main message is that that there's no difference in outcomes from a standpoint of mortality if patients are treated with a continuous versus an intermittent modality. How about the effects on hemodynamics, which is important to all of us? So if you look at hemodynamic instability or the incidence of low blood pressure or the need for changes in vasopressors, so increased vasopressor requirement, there's uniformly a trend in the risk ratios being lower for continuous modalities. But in all of these, the confidence intervals are wide. So this is telling us, clinical studies are sometimes tough to interpret. Meta-analyses have a lot of heterogeneity. So there's certainly a trend for these people to tolerate hemodynamics better. And all of us who see patients know that the guy who's very hemodynamically unstable, you put him on a regular dialysis machine, they tend to crash more often. You use a continuous modality, you're actually able to manage them a lot easier. So this is the difference between what the literature is showing and what we can do at the bedside. So I'm showing you the data, but I'm also telling you that there are some patients that you absolutely cannot manage without a continuous modality. Mean arterial pressure, as you see on the bottom, does increase a little bit when patients are on a continuous modality. So who should be on a continuous modality? Well, the only one that I'm not going to show you the primary data, but the only one that there's general agreement are people with liver failure. And that's mostly because the osmotic changes associated with intermittent dialysis are associated with increased shifts and detrimental effects on intracranial pressure in these patients. So patients, especially with acute liver failure, decompensated cirrhosis, hepatorenal syndrome, awaiting transplantation, those are the patients to treat with a continuous modality. Everybody else, it probably does not make a difference. So everything else that I'm saying here, those are, things to entertain the value, but in most patients, it probably does not make a difference. How about dose? This is how aggressive the treatment should be. Dose either of CVVH, measured as the amount of replacement fluid that you give per hour, or in intermittent dialysis, how often you dialyze the patients. So above the green line, you see the data for continuous modalities. You see in this column here the doses used in each study and the mortality difference. We have 2 studies in which patients with the high dose did better. we have 3 studies with no difference between the two. I'm going to show you the biggest and most relevant study in a second. For continuous dialysis, for intermittent dialysis, 2 studies here at the bottom, one showing a marked difference. I remember many years ago giving this talk, I used to say, there was a slide I used to say, more is probably better. Now I'm changing completely what I'm saying. And here in the largest study, in my opinion, definitive, we participated in this study, no difference. So let's look at these 2 studies that I think are most important. The first one for intermittent dialysis, there were patients both on continuous modalities and intermittent modalities. Patients who were on continuous had a low and high dose. Patients who were intermittent were either daily or 6 days a week. And then the data were lumped together. As you can see, mortality, there was no difference between the 2 groups. When you look at a variety of subsets according to severity of cardiovascular dysfunction, gender, the presence or absence of oliguria, the SOFA cardiovascular score as a marker of hemodynamic instability, no difference. This is a negative study, as negative as it gets. So there's no evidence that going to a higher dose makes a difference. But you got to deliver the dose that you're planning. So if you're planning on delivering 25 mLs per kilo per hour in the CVVH, you got to make sure that they get 25 mLs per kilo per hour and that they are dialyzed most hours of the day. Not that the CVVH machine stays off for 8 hours because there's something with the nursing staff or the filter clotted and nobody came to replace it. If you're delivering dialysis, you got to make sure that a KT/V of 1.2 to 1.4 is delivered, which means you got to measure it. Which is, KT/V, for those of you who don't know, is a measure of urea removal during dialysis. So you've got to deliver the dose of dialysis that you're targeting, and then it doesn't matter if you dialyze 3 days or 6 days a week. This is for a study restricted to patients on hemofiltration. They were randomized to either 25 or 40 mLs per kilo per hour, mortality at 90 days, no difference, a variety of other outcomes, hospital days, mechanical ventilation days, ICU days, no difference. Okay? So probably we do not need to go high. More is not necessarily better if you deliver the standard amount effectively. And this slide gives you that final recommendation with specific numbers based on these data. So this was my summary about acute kidney injury. I hope you enjoyed it. Thank you very much.